Hi, welcome everyone. Today we will discuss about acute hematuria. I'm your instructor, Dr. Junaid. Let's start the topic. Acute hematuria refers to the sudden appearance of red blood cells in urine. It is a clinical sign, not a disease, and can result from disorders anywhere along the urinary tract, that is, from the kidneys to the urethra. The key to management is rapid differentiation between benign and serious causes, including malignancy, infection, and trauma. And we classify hematuria as gross hematuria, which is visible to the naked eye, microscopic hematuria, which is visible under the microscope, and acute hematuria depending upon the onset. Sudden onset is acute hematuria. Pathophysiology of hematuria, basically we will differentiate between glomerular hematuria and non-glomerular hematuria. The glomerular type occurs when the filtration barrier is disrupted, allowing erythrocytes to pass into the urine, and non-glomerular hematuria arises when bleeding occurs beyond the glomerulus, such as from stones, tumors, or infections in the urinary tract. Understanding the pathophysiology helps to direct both diagnostic and management strategies. Clinical presentation. Clinically, gross hematuria typically presents with discolored urine, while microscopic cases may remain asymptomatic. Pain often suggests infection or stones, whereas painless hematuria, especially occurs in older adults, raises the suspicion for malignancy until proven otherwise. The presence of clots usually points to a lower urinary tract origin, and also you will see you will differentiate on the basis of the shape of the clots. If there is rounded clots, it means the source of hematuria is from the lower urinary tract, that is from the either starting from the urinary bladder. And if a patient gives a history of passing elongated clots, then you will assume that these clots are passing from the upper tract, and likely there is upper tract malignancy present, like upper tract transitional cell carcinoma. Differential diagnosis. Not all red colored urine is true hematuria. Laboratory confirmation with microscopy distinguishes red cells from free pigments like hemoglobin or myoglobin. Clinical correlation is crucial to avoid unnecessary investigations. Common causes of hematuria includes like UTIs, stone disease, trauma, exercise-induced hematuria, and benign prostatic hyperplasia. And serious causes can, in serious cases, hematuria can arise due to bladder or renal malignancy, glomerulonephritis, either renal vascular lesions or coagulopathies or anticoagulant use can lead to the medical hematuria. Then we will differentiate between glomerular versus non-glomerular clues. Like when you will assume that hematuria is arising from the glomerular source, when in urine complete shows our presence of RBC casts, dysmorphic RBCs, proteinuria, hypertension clinically, and edema present clinically. Most probable origin is glomerular. And in case of non-glomerular hematuria, there will be normal RBC morphology and clots will be present there, and pain and infection signs are typical of non-glomerular hematuria. Initial evaluation depends upon the history, which includes the onset of hematuria, duration, either it is visible or microscopically it is present, either it is painless or painful with the passage of clots. And you will also in history you will also acquire about the urinary retention due to clot passage. And also patient will complain of other symptoms like pain, fever, and also you will take history about the usage of any anticoagulants or blood thinners taken for ischemic heart disease in recent times or recent infections, family history of stone disease or renal disease. And physical signs, there will be a flank tenderness and patient will be hemodynamically unstable if there is continuous hematuria. It will mostly patient presents in state of shock, hemodynamically unstable patient. Diagnostic workup. In laboratory workup, urine analysis with microscopy, urine culture, CBC, coagulation studies, creatinine, and GFR are crucial for diagnostic workup. And in case of imaging, when patient presents with gross hematuria with clots, we will go for computer tomography scan with uh, with the help of contrast, which is known as CT urography. Secondly, ultrasound can be done in pregnant patients, pediatric populations, and in case of renal failure. And cystoscopy is indicated in patient more than 35 years age or with persistent hematuria or cancer risk factors. What are the key red flags in patient with hematuria? First of all, gross hematuria without any infection, presence of clots, age more than 35 to 40 years, occupational exposure of dyes or chemicals like bladder tumors are mostly associated with occupational exposures. History of smoking is also related to the malignancy of urinary bladder. Anticoagulation with hemodynamic instability and elevated creatinine are systemic signs. What are the management principles for hematuria? Initial management focuses on stabilizing the patient, maintaining his urine output, treating pain, and preventing urinary obstruction from clots. Subsequent therapy targets the underlying etiology. In severe hematuria, continuous bladder irrigation may be necessary to prevent the clot retention. Specific management approaches. Each underlying condition has distinct treatment protocols. For glomerular causes, immunosuppressive therapy may be indicated. Antimicrobial therapy should always be guided by urine culture results. Traumatic and malignant causes often require multidisciplinary involvement. To conclude, acute hematuria is a common but potentially serious clinical finding. Early evaluation, correct differentiation of cause, and prompt management significantly improve patient outcome. Always consider malignancy, especially in older adults with painless gross hematuria until proven otherwise. Then go for the workup until you get CT scan or any clinic or any radiologic evidence of malignancy. So that's it from today's lecture. Hope to see you in upcoming lectures. Take care till that time. Good luck to all of you. Bye.